So as we all know that the whole urinary system is divided into the kidneys, the ureters, the bladder, and ultimately the urethra. So before we are going to understand the discuss about the USG or IVP anything, we should actually understand what is the anatomy of the kidneys, so that we'll be able to better interpret what are the other pathological changes, right? So as we just see, these are two bean-shaped structures which are present at the just adjacent to the vertebra at the level of L1, L2. The right kidney, as we can see, is a bit lower down. Why is it bit lower down? It's being pushed by the liver. Okay, so basically this is a bit lower down, this is the up, and whenever we decide the level of the kidneys, it is at the level of the hilum. So if this is L1, this is L1, L2. So this is the L1, this is the L2, this is almost L1, this is L1, L2 level. So this is the basic thing which we need to first understand. Second important thing is that the normal anatomy of this, it is having a size that is almost around 9 into 5 into 3 centimeters. Anything which is below or above this is something which is not going to be normal. The third important thing is that it is having three important areas which are basically there: the artery, the pelvis along with the vein. So there are three different structures which are basically entering into the hilum. What is the basic orientation of these three structures? It is decided by VAP, from anterior to posterior. The first structure that we encounter is the vein. After that is the artery. After that is the pelvis. Okay. So three structures are coming across. Pelvis is something, after that the ureters are getting connected to. Okay. And thereafter obviously the entire ureter will come across. When we see the cut section of this, it is the basic kidney which is divided into the cortex and into the medulla. As we can see, this cortex is something which is the main part where the urine formation is taking place, and the whole concentration is taking place at the level of the medulla. After this, it is basically entering into the pelvic calcial system and thereafter draining into the ureter. So this is the basic thing or pathophysiology which is basically encountered. As we can see, these are almost seven minor calyces which come across. 1, 2, 3, 4, 5, 6, 7. This is almost constant. So there are 7 minor calyces which are there. These 7 minor calyces are thereafter draining into 3 major calyx: the upper calyx, middle calyx, and the lower calyx. And thereafter these major calyxes ultimately form the pelvis and thereafter the ureter. So this is how the whole anatomy of the kidney takes place. So now the similar anatomy as we understand in the IVP. So this is the upper, in the IVP we are not able to visualize the cortex or the medulla very nicely. What we are visualizing more is something which is the pelvic calcial system. We can just have an outline of the kidney. See, this is the outline of the kidney. You can see there is a faint line coming across. It's not the complete structure, but there is a faint line which we can see. These are the major, these are the minor calyces which I told you. As I'll just show. This black portion is the minor calyx which is entering into the white portion, that is the major calyx. So there are upper calyx, there is middle calyx, there is lower calyx forming the pelvis, ultimately entering into the ureter. So this is the way it is actually going to be. I have already told the whole entire thing in the previous slide itself. Then coming to the ureter, so we have basically 2 ureters, one on each side. Its length is almost around 25 to 30 centimeters and its internal diameter is almost 3 millimeters. It's a very narrow tube. What is important to note is there are 3 different functional areas where we are going to find the ureters at a lower end, or we can say a narrowed segment. These are at the junction of the pelvis as well as the ureter. It is at the pelvic brim where it is crossing the iliac vessels, and thereafter when it is entering into the bladder in the intramural part. So there are 3 different physiological constrictions which are seen in the ureter. Apart from that, if we find any constrictions in the imaging, that becomes again pathological. So again we are basically going to look at the normal ureteral anatomies. We already know the upper calyx, the middle calyx and the lower calyx, pelvis and thereafter this is the narrow line which actually enters and ultimately forms the ureter. When are we visualizing this particular ureter in the IVP film? We will see in the later sections. It is almost around 15 minutes from the injection of the, from the time we are basically injecting the dye. Okay, till that point of time we are not going to visualize the ureter at all. So this is basically the whole length of the ureter. What is important is the other structure that needs to be identified. If you are able to, then we'll just have an idea. There is a faint line which is going here, and there is a faint line which is going here as well. This is the line of the psoas muscle. Okay. Apart from that, there are the 17 whatever these dark shadows. These are basically gaseous shadows. So it is something which is the bowel shadows, and many a times if we are not having a very good bowel preparation, we are going to miss out on many of the important findings. Small stones which are radiopaque shadows seen on within the X-rays can actually get obscured because of these bowel shadows coming in between. So these bowel shadows need to be understood. This psoas muscle, there is a faint outline which we can also see from the kidneys. This particular outline, you can see this, a very faint outline is there, but that is actually showing the level of the kidneys. Apart from that, this is the bladder where it has actually already entered, and this is the pelvic ileal system. This pelvis is not the normal pelvis. This is a bifid pelvis. A normal pelvis is looking like this, a balloon shaped one with all the three areas coming together. Here we can see there are two different at right angles. So this is a bifid pelvis. Okay. So there are various imaging techniques which are there in ultimately helping us to track the whole urinary system. The most common of all is a USG. Apart from that, there are X-ray. X-ray with a contrast is known as IVP. There are the three-dimensional imaging structures, which is the CT scan and the MRI. A CT scan again can be contrast and non-contrast, and nowadays the more advanced versions are contrast with a urography. So what is a urography? It is nothing but 3 phases in which the CT scan will be taken so that we can have a better visualization of the entire length of the urinary tract. So as I just said, these are a few important IVPs and ultimately imagings which we will be seeing in the later run. Just this I have already discussed. This is the absolute normal IVP imaging. We can see that there is no dilatation in the entire length of the urinary tract. This is a normal IVP plate which is there. This one is something which is basically you can see there is a small shadow out there in the renal area. So this is basically a stone. I was just saying that we can have a faint idea about the kidney outline. So this is the kidney outline which is there. This is basically not having any pelvic ileal system that is getting enlightened. So basically it is a control film. It is a non-contrast film. It is basically a plain X-ray KUB. A normal X-ray which will be able to easily identify the stone if it is actually having a very good bowel preparation. And this is something which is an IVP imaging. This is an RGU study which we'll be basically seeing later. So pelvic ileal system, as I just told, it can actually have multiple anatomical abnormalities, and that is the reason we do the imaging, right? So the first abnormality that we see is a duplex collecting system. So basically in a duplex collecting system, what are we basically seeing here? This is a normal anatomy, right? What is a duplex collecting system? It can be basically having one ureter that is going here, the other ureter that is going here. This is basically connected. These both ureters can join later on, ultimately forming a single one. This is something which is called as a bifid ureter. Suppose this whole length is not joining and it actually remains as a separate entity and enters separately. Something which is basically called as a double ureter. So there are two different abnormalities. One is a normal, one is a single ureter bifid system, one is a double ureter. So this is basically the double ureteric system. Now what we need to understand is something which is a very important rule, something which is very commonly asked in the examination, in the practical examination, something which is called as the Wiegert-Mayer rule. So what is a Wiegert-Mayer rule actually? I think I have slides for that, but just will give you a brief idea about this. So in Wiegert's-Mayer rule, what is happening, there is an upper moiety kidney, there is a lower moiety kidney. Both are basically having their own ureteric supplies, right? What happens, the upper ureter normally drains on the medial aspect and more inferior level, while the lower moiety drains at a lateral aspect, it actually drains at a lateral aspect and more superior level. So this is basically the Wiegert's-Mayer rule. How can you remember this? It is called as SIMO. S for superior, inferomedial insertion. So more inferior, more medial insertion. And O means what? Since it is having a longer length in the bladder, the chances of it getting obstructed is more. So it is basically having more chances of obstruction. So SIMO is the word by which we can remember this. Superior actually has inferomedial insertion of the ureter, along with it is more obstructive in nature. So this is basically the Wiegert's-Mayer rule. Now in this situation also we can just see this, as we will trace down, this is the upper moiety. If we trace down, go, ultimately we find this is going more inferior and medial. This has actually entered very above. The whole entire length has not come, but this is a better imaging. No. So this is basically having something ballooning which is seen at the entrance of the bladder, what it is. So this adenoid appearance is because of ureterocele. So what is exactly a ureterocele? Basically it is because of the weakening of that particular area, so that there is dilatation of the whole mucosa, and ultimately it gives rise to a cystic dilatation of the lower end of the ureter, something which is known as ureterocele. We will be having a look at the ureterocele and the later films. Okay, now this is an important film that comes across, something which is known as a drooping lily sign. So where do we find a drooping lily sign? Again in a patient which is having a very enlarged non-functioning upper moiety. So what has actually happened in the drooping lily sign? Basically this is a pelvic, this is a very enlarged system. What it actually has done, the whole thing gets compressed here and ultimately starts to look below. This particular enlarged segment has actually caused compression of the lower segment, and that is the reason the lower segment starts to look down. It is something which is called as drooping lily sign. So it refers to a drooping lily sign is actually seen in a duplicated renal collecting system, and it is basically because the lower upper moiety is something which is obstructing the lower moiety. Then there is a very important thing called as UPJO. What is a UPJO? This drooping lily sign will come again in the later slide, so I'll have a better pictorial presentation for it. So what is a UPJO? Why is it caused? So the most common reason why a UPJO is actually caused is because of two things. One, it is because of any crossing vessels. Crossing vessels means we will have certain anatomical accessory vessels which are crossing this particular area. So ultimately it will block the whole entire ureteric tube, and henceforth what will happen? There will be dilatation of this area because the urine passage is getting blocked. We are having a vessel that is crossing here, it is compressing on the ureter, ultimately not allowing the urine to come and ultimately enter inside. So this is one reason, but that is the minor reason. What is the major reason? The major reason is an intrinsic defect in the circular muscle fibers at the level of UPJO. We have heard about pacemakers inside the heart. In the similar manner, there are pacemakers which are present at this area as well, which helps to basically drain whole entire length of urine inside the pelvis into the ureters. If we are basically having that particular area getting damaged because of the circular muscle fibers that's become defective, ultimately what will happen? It will basically have the whole entire urine getting collected in the pelvis, giving to a dilatation of it, and the ureters will basically remain narrow. There will be no dilatation of the length of the ureter. This is what we need to understand here. Suppose if the ureter was also dilated, then the pathology would have been in the bladder. If the ureter is absolutely normal, if the ureter is completely thin, but the whole entire kidney is actually like a bag of water, In that situation, the pathology is at the level of UPJO. Okay. These are also having certain gradings. This is also already at a higher grade because only the pelvis can be dilated in the initial levels. But now in this area, we can see that the whole calyces, these are all minor calyces which are also getting dilated. And henceforth, the cortical thinning will take place. So this is basically an advanced version where it has been basically not been seen or dealt with at an earlier age, and the patient lands up at a very later age. Normally, what is the age of presentation for a UPJO? Can anybody tell us? A UPJO is actually a silent or an asymptomatic condition. The patient does not know about it, although it is congenital, but they land up at the age between 30 to 40 years. So at 30 to 40 years, suddenly they basically have mild pain, or sometimes just because of an incidental USG that they have done for some other reason, they find that they have actually a whole entire kidney which has become swollen. So this is a presentation that actually takes at a very late stages. But suppose we actually can deal it at a very earlier age, then the results are even better. The kidney can actually get back to its normal level. So as we can see, this is an asymptomatic condition. When it becomes symptomatic, it's already at an advanced stage. And what kind of a symptoms will be there? The urine that is collected inside the bag becomes infected. Ultimately, it will give rise to urinary tract infection. A urinary tract infection will give rise to stone formation. So there will be secondary stone formations as well. So these two are the most important thing that takes place. And if it is becoming huge, then ultimately they will come as a mass that is actually palpable. So many a times patient says that I just had a mass, no pain, no nothing, but what has happened to me? So this is a normal presentation. Most of them are asymptomatic in nature. As I just said that actually this was the IVP image I showed, but then the ultrasound is actually also there. This ultrasound, as we can see, the whole pelvis has become dilated. These are the calyx which has also become dilated. Ultimately, these are the minor calyces. So when the minor calyces also become dilated, this is the cortex portion which gets compressed. So henceforth, the functional level of the kidney becomes decreased. So this is basically the last stage that comes for the UPJO. What is the absolute last stage? Here we can see a little amount of cortex. This black shadow is the cortex. If there will be no cortex, it will be just a complete bag of urine. It's called as a non-functioning kidney, the last stage where the UPJO can take place. And it can actually get even worse by having a development of pus inside it, something called as pyonephrosis. So this is the pyonephrosis which takes place. So pyonephrosis is not only because of the UPJO, but it can be because of any system which gets infected. What we need to understand is that normally a pyonephrosis, the word pyo means pus, and pus in the body, if it is present anywhere in the system, it will cause fever, it will cause chills, it will cause other symptoms as well. So this pyonephrosis is something which will be basically symptomatic. Like the UPJO was silent, pyonephrosis is always symptomatic. The patient will run and ultimately come and visit to us. So in a CT scan, what we are going to find in the pyonephrosis is basically there will be a thickening of the wall. Any particular area which gets inflamed will develop fibrosis. Ultimately, that is the last stage, but initially they will have edema, they will have inflammation, and that will cause a thickening of the wall. So they will basically have inflammatory changes, they will have dilatation, they will have obstruction of the collecting system. What we need to do, see here we can see two things. The stone, actually there was one more better plate, but there is always an underlying cause. As I said, the underlying cause can be a UPJO, but suppose a patient had a pelvic ileal system stone. A stone was obstructed here, and he actually left it as such. He said, okay, it will come out. There are homeopathic options, we'll take that, it will come out. 1 year, 2 year, 3 year. And now this patient suddenly comes and lands with a huge acute pain, fever, chills. What has happened? It is basically this particular area has obstructed this system. This system basically thereafter later became infected, and ultimately this whole area got hydronephrotic, and this particular thing is the collection out here. The collection is better seen in this area. You can see this. This is whole a collection. A collection is always isodense in nature in a USG. Okay, this is, yeah. So this is basically a normal USG. So how a normal USG of a kidney looks like? Can anybody say me? Can anybody explain me this slide? Absolutely. So this black line or the black shadow is the cortex. And whenever we are saying any words regarding the USG, it is hypoechoic or hypodense. Which one? It is echoic. It is basically the echo which we are basically seeing. Okay. So this is hypoechoic and this is hyperechoic. Hyperechoic area is the medulla. Why is it hyperechoic? Because of the medullary fat content. Fats are always echogenic. So whichever area will have fat, it will be echogenic in nature. Angiomyolipoma, it's echogenic in nature. So basically this is the normal corticomedullary differentiation. We can very easily make out there is a contrast that is present between the two. Normal cortical thickness, this is basically the area where there is no in between hypodense shadow. If it is there, it is hydronephrosis. Okay. Now, can you actually see any difference between this kidney and this kidney? So it has become echogenic. Dense is a word that is used for CT scan. Yes. So it has become echogenic. And how do we basically say? It is always in terms of the liver. So any echogenicity is decided by in terms of liver. We take liver as isoechoic. Anything which is above it is hyper, anything which is below it is hypo. We can see this is below it, so it is normal. We can now see that it has become even brighter. The cortical area has become even brighter. So what does it actually signify? It signifies the disturbance between the corticomedullary differentiation, something which actually happens in patients who are having chronic renal disease, CKD patients. So any CKD patients will actually have CMD which is getting altered. Also you will see if you actually measure the size of the kidney, it has become shrunken. It has got shorter in size, and that's because of the repeated cortical scarring that takes place. So that is something which is the difference between a normal kidney and a kidney which is CKD. Anything which takes place is always in reference to the liver. If not liver, then what? Spleen. Okay, so these are the two structures by which we are going to take the reference through. So I just said hypoechoic is something which is dark, hyperechoic is brighter and white, and we are always taking liver as the main isoechoic area. Something which is absolutely black without echos is something which is, it is something which is air. Okay, so pyonephrosis was done. Now today I am not going to basically have more of theory. It is all going to be pictorial presentations, and we'll just have what is actually the reference through it. I just wanted to know, show you that we know CT scan is having contrast, we know MRI is also having contrast, we know X-ray is also having contrast, but we should also know, which is a favorite question of the examiners, does ultrasound have contrast? It actually does have a contrast. Then what is the contrast material that is used in ultrasound? It is actually the air. So the microbubbles, administration of contrast agents which actually has microbubbles. These microbubbles are actually used as a contrast material in ultrasound. You just need to remember that, you don't need to enter into details of it. Just remember that nitrogen gas or perfluorocarbon microbubbles, they are the ones which are basically taken as a contrast material. So as we can just see, this is a normal transrectal ultrasonography of prostate. Okay, you are basically seeing everything is black and nothing is actually coming across. Once we basically enter air inside or that particular contrast material, they are basically getting accumulated in this particular area which becomes hyperechoic. Also this particular area which becomes hyperechoic, which is basically suggestive that it is very valuable if we are suspecting a prostate cancers. So what I just want to know, tell you is that there is contrast material which is also available for ultrasound. Just remember that is air. Which type of air? It is microbubbles of perfluorocarbon or it is nitrogen gas. That is the only thing you need to remember, nothing else. Now tell me this. What is this? Can anybody say that? That's fine. Can you tell me any of these four things which is actually what? So how do you say this is a renal cyst and not a hydronephrosis? Well circumscribed is one thing, very good. Anything else? Acha, what are the things which we are seeing here? First, this is the liver. Doesn't matter whether it is liver or this is the kidney. It's the simple fact. This is a normal boundary of the kidney. This is the normal cortex. We are seeing from the liver, this is a bit black, so it is normal. Absolute black is not required. We are going one by one. Liver we have seen, this is more black than this. There is a white structure out there. So this is a normal kidney in its one pole. Lower or upper doesn't matter. One of the poles is normal. The other we can find is a large black shadow. Okay? So basically this can be either a hydronephrosis or a renal cyst. How to differentiate between the two? In a renal cyst, there will be a well circumscribed boundary as he told rightly. Apart from that, there will be no connection with the other part of the pelvic calycial system. If there is a connection with the other part of the pelvic calycial system, that means this is hydronephrosis. This is hydronephrosis. You saw, this is basically a single area, no connection here. Now here what has happened, the whole entire length of the pelvic calycial system has connected with themselves, getting dilated, almost compressing the medulla. Medulla white structure is almost not visualized. If we basically have even more time, this cortex will also get compressed, the kidney gets damaged. So this is a basic thing that will be asked in examination. What is a renal cyst? What is a hydronephrosis? A difference between the two things. Okay? Now this is a CT pictorial image of something which we have already discussed. This is not pyonephrosis actually. You cannot comment pyonephrosis straight on. For a pyonephrosis, you should basically have a contrast image in the excretory plate. This is the cortical phase of the contrast of the CT scan. In the cortical phase, we are only seeing the kidneys. The whole ureters are not well visualized. So when the ureters are well visualized, it is the pelvic calycial system which will be basically getting also enlightened first. If it is not getting enlightened with the contrast, you can say that that may be a pyonephrosis. In a normal water, it will get enlightened, but it will not drop down. But pyonephrosis, it will not become hyperdense. So that may be a pyonephrosis. To comment that, we are requiring a excretory plate. Okay? So this is just saying that there is something which is problematic here, something which has actually accumulated inside the kidney, compressed onto the whole cortex, and the whole cortex has become a thin rim. This particular thin rim outline is called as a rim sign. R-I-M, rim sign. So rim sign is something which is seen in patients who are having chronic hydronephrosis. This chronic hydronephrosis can be because of a UPJO obstruction that I just told. So it can be a similar finding out there, first. Second, this similar finding can be seen if there is a chronic obstructing stone which was in any length of the ureter, whether it is PUJ, anything. So that is the reason you will never comment this as a UPJ obstruction. You will always say this is a chronic hydronephrosis, which has led to a thinning of the cortex leading to the cortical rim sign. Okay? You will never comment which is what? The pathology is later decided. Sir, I want more plates to define the pathology. Something different for MCQs I have just given. They will never ask, they don't know also. Reverse rim sign. Reverse rim sign is something which is basically having, you can see I just told that the cortex is absolutely getting hyperdense, a white line, right? In the rim sign, we are having the cortex becomes hypodense. It's just the opposite. Rim means it has become enhanced. So the inner ring has enhanced, but the outer rim is not. So it is a reverse rim sign. And that is basically cortical necrosis. The cortex has become necrosed because of some terminal blood vessels getting damaged. So this is something which was also above my knowledge as well when I was there. This is something which urology has taught me. Huh? Renal papillary necrosis is something which will be happening at this particular level. The papillas are here. Medulla is actually having a papilla. This papilla projects into the pelvic ileal system, then enter the urine. So it is in the medullary part. If we are having it in the cortex part, that's not renal papillary necrosis. Okay? This is something interesting. Can anybody say what has happened? The slides also say something, but anybody can say what has happened here out? That is written, but can you interpret this, what has actually happened out here? So first of all, this is a CT scan plate. It is a cross-sectional imaging of a CT scan. This is the normal side kidney. This is the liver outline, so this is the right side kidney. Right side kidney has taken the contrast well enough. Since the ureters are not having the contrast, this is the cortical phase of the CT scan. I am not going into details of CT scan today because that will be a next class imaging. Okay? But I am just giving an idea that this is a normal CT scan of the right kidney. What has happened to the left kidney? Can you identify where the left kidney is actually? So the left kidney is this. It has gone way above. Why? Because of a hematoma. So that hematoma is because there is a huge lot of blood loss which has taken place. Now why this kidney is so black and why it has not brightened up like this particular kidney? Because of the, no, because the blood will never cause this particular kidney to not get bright. It is because the total avulsion of the vessels have taken place. The blood supply is cut off. Since the blood supply is cut off, ultimately the whole kidney has become black and necrosed. Suppose I give you a similar situation, the whole hematoma is collected here, but this is a white kidney. If that means the avulsion has not taken at the level of the vessels, it is basically the cortex which has got damaged. From cortex we have bleeding, that bleeding has collected here, kidney has gone up, but the kidney is still functional because it is brightened up because the vessels are still entering. But in this situation the vessels have cut down and there is a complete avulsion, the kidney supply is gone, huge blood loss, so the amount of hematoma is also high, the kidney outline has getting disturbed and the kidney gets up. So this is a typical renal trauma, which is a grade 5 injury, the last thing that we can think of. Okay? So this is something which is renal trauma. This is the first plate that you are going to get in your examination, and you have to basically say how you have to say basically that this is a plain scagram of this and this. It is showing presence of a rib outline, it is showing presence of pelvis, it is showing the vertebral outlines, but then what else are you seeing out here? So there is some radiopaque shadow which is basically seen in this area, and that radiopaque shadow comes out in the renal outline. The interesting question out here is not this radiopaque shadow, everybody will say it's a renal stone. The interesting question is it a gallbladder stone? How will you understand it's a gallbladder stone? This is the question that is asked in the examination. Huh? So I am saying it's a radiopaque stone. Now tell me how it is to be understood. 10% chances gallstones are radiopaque. 10% chances renal stones are radiolucent. I am saying both of them are radiopaque in this situation. How will you understand whether it is what? No. So you will ask for a lateral view film. So in a lateral view film, what will happen? If suppose this is the vertebra, if this was a gallbladder stone will remain in this position. If it is a renal stone, it will almost come here. So this is the favorite question asked by the examiners. How will you basically differentiate between a right-sided radiopaque shadow in a plane skygram? So whether it is a gallbladder stone or this, we require a lateral view film. If there is a medialization of the stone almost nearing to the vertebra, it's a basic renal stone, because actually the kidney is something which is just lying beside the, it's a paravertebral structure, and a gallbladder stone, it is a gallbladder, it's something which is very much away from this. Okay, clear? Acha, there is something which is out there. What is this? Time koto hoyche? Oh Baba, slides to bahut bachi hain. Should I go continue or you will continue? Acha, can you tell me what is this? 20-15 minutes I'll take extra today. Thoda sa late aaye isliye. So this is basically a double, a tube that you can see with two ends as a double J. So it's a double J stent. And where do we place these stents? These stents are normally placed post surgery. Whether it is a kidney stone, whether it is a ureteric stone, we place in these stents. Post pyonephrosis, we want to drain the pus. Post ureteric stricture, we want to dilate the stricture, we want to basically dilate the whole length of ureter, we place in a stent. You know, a stent is placed in the heart. It is basically to relieve obstruction. It is wanting to drain the whole blood. Same thing, wanting to drain urine, wanting to drain pus. Done a surgery, ectopic injury we have done, we want the ureters to heal. So basically post surgery, stenting. So this is the basic thing. So these are the basic areas where we put in a stent. Achha, there is one shadow that was shown here, very faint. I don't think so you will be able to locate, but there is still a stone that is present out here. There is still a stone that is present out in this area. So people will ask you what it is. So it might be a residual stone which was left behind. It might be a pus which was drained first, and then the patient will be next taken up for the surgery. The pus was formed because of the obstructing zone in the PUJ. Right? Now, can you say about this? We'll go quick, thoda sa. Can you say about what is this? You can find there is a normal system out here, but you are not able to find a normal system out here. Is a renal agenesis taken place? No. You have to see the entire length, not the only here. So there is some line that has come here. So that means this area, if you are seeing, that has actually being overshadowed by the pelvis, it is actually having the pelvic elation system at this level. Something called as ectopic kidneys. Ectopic kidneys are actually at the level of pelvis, which is the most common thing. So don't just hurriedly say that, sir, there is no kidney out there. It might be a nephrectomy, it might be a renal agenesis. No, you have to see the entire length, and then you have to judge that really this is there. Suppose if this is not there at all, sir, I still want more plates to confirm my diagnosis. So if this is the whole thing, you can see very faint area, you can see this is the normal system. There's a small kidney out here, it is basically the ectopic kidney, right? Same thing, almost entering into the pelvis, there is a kidney which is sitting out there. So it is basically a CT scan plate showing this ectopic kidney. This, what is this scan? This is actually a DMSA scan. It's a DMSA scan. Again, DMSA scans can actually highlight the kidneys. You can see the two different levels of the kidneys. One in the pelvis, the other is actually in the normal areas. So DMSA scan is there, CT scan is there, IVP is there, USG is there, many other things are there. USG can miss it because many of the people who are doing the USG are observer dependent. If they are not able to see it nicely, we have to always confirm the findings. Don't say renal agenesis. What is this? So basically this is not double ureter. Pelvic elation systems are present, two pelvic elation system in the same side. And that means that there is no pelvic elation system in this particular area. So what does it actually show? It shows that both kidneys are in this particular location, something which is called as crossed ectopic kidney. So the ectopic kidney is this, pelvis was here, I have just switched on in this area. So it becomes ectopic but crossed. So it is something which is crossed ectopic kidney. Now this crossed ectopic kidneys can also be of two different types. I'll just show you that. If this crossed ectopic kidney is fused together, something which is like this, it is called as crossed fused ectopia, a very famous MCQ. So crossed fused ectopia is two systems on same side but both kidneys are together. If suppose both systems are different, then it is crossed but not fused ectopia. And if suppose there is one system that is going there, one system that is going there, it is basically bilateral crossing, a very, very rare anomaly where we are seeing that the right kidney drains in left side, left kidney drains in the right side. So as I was just saying that actually IVP films, they will always ask you what are the different phases of an IVP film. So it's always having a control plate which is basically there. After that we are going to take a control plate is first plate. Immediate film is obviously in the nephrogram phase when the kidneys get highlighted. After that is 5 to 15 minutes. As I said, the ureters will ultimately start, the pelvis starts to getting enlightened. And then the ureter is completely very nicely visualized at 30 minutes. The bladder will be visualized at 45 minutes. And most probably they will have a 45 minutes later on, we'll ask them to void. It should be empty. That is a post-void film. So these are mota moti the 5 plates or 6 plates of an IVP with different phases. As we can just see, this is a control plate. This is basically the secretory phase where basically the pelvic elation system starts to get highlighted at 5-15 minutes. They are even getting dense. The ureters are getting visualized at 30 minutes. Bladder is first seen at 45 minutes and now the bladder is empty at 45 minutes. So this is a entire phase films of an IVP. Again showing the same thing, no point. Now this is interesting what it is actually. Can anybody say what is this? So basically there is a pelvic elation system here, there is a pelvic elation system which is here, there is a ureter which is here, but the ureter should be actually at this level. Here the ureter is here and there is a calyx which is pointing in this direction, which is medially towards the vertebra. It's a horseshoe kidney, very nice. So basically this is the calyx which is pointing medially, this is the calyx which is pointing medially. The ureters are at lateral positions. They are both basically shaking hands with each other like this. So it's called as a shaking hand sign. So shaking hand sign is at this level below, but what is at above? It is called as a flower vase sign. So basically two signs in horseshoe kidney. I'm going a bit fast now. Two signs in horseshoe kidney, flower vase sign which is above and a hand shake sign which is below. What you need to remember, inferior calyx is pointing medially. This is the highlight point for a horseshoe kidney. In all calyx is pointed laterally. In this case, inferior calyx is pointing medially because it is getting fused and this particular fusion is called as isthmus. Now what we need to understand why this kidney did not get up. This is an MCQ that is asked. Because of this artery. Can you, yes, this is the inferior mesenteric artery. So this inferior mesenteric artery did not allow the kidney to get ascend and ultimately they both joined and that actually led to the formation of a horseshoe kidney. Should I end the class here or can I continue for a bit? Jaisa everybody will say. End? So we'll take up it next session maybe. We can just say this is basically the horseshoe kidney connected together. Here it's the same thing. Here is the same thing. This area is actually called as isthmus. You can see this area and this area, they are pointing laterally, but ultimately the calyx in this area, this is pointing medially. So this is the thing. I was just, one last slide maybe. I was just saying about something which is the drooping lily sign. I just went very fast through that because I wanted to show a figure to you. So this drooping lily sign, you can see this is a normal figure of a pelvic elation system. Here it's like, oh, murjha gaya. It's a drooping that has taken place. Why? It's because of this. The whole entire upper moiety has become so enlarged, it has compressed onto this particular one and it has actually started to see below. Now this enlargement can be because of 2 points. One is basically because of an obstruction maybe that obstruction will be associated with the ureterocele. The other cause might be a RCC, renal cell carcinoma, which has enlarged in a duplicated system, compressed onto the segment. So don't be judging only on one thing, that it's only non-functioning segment, it can be a RCC as well. Okay, we'll be finishing the class today. Many more slides are there actually, interesting slides. अच्छा ये last करके छोड़ देते हैं. What is this? This is bladder, that's good. And what is this? What is this? Is this a contrast? It is not blood. You will not come in blood like this. In an X-ray, a blood is not seen as a white shadow. It is basically a calculus, a very, very large calculus. Entire bladder is actually covered with it. And if we cut through the sections in a CT scan, we are able to see multiple, yes. And when does it happen? You have seen a tree growing and a cut tree is always having this, janmo se bada ho raha hai. It's getting stronger and larger day by day. So it is basically through the different layers it has actually formed. All these layers are strengthening this particular stone. It's a very hard stone. Vesical calculus are normally very, very hard, and it's very time taken to break.